And hello everyone, I'm Talisha from the Progressive Podiatry Project. You're joining us for the Sunday Roast. Today I'm joined by Kirsty, the Lifting Pod, and Aaron Wilson from Aaron Wilson Rehab. So just a little bit of an introduction, because this is the first episode with all three of us on board, is I am the director of the Progressive Podiatry Project, a continuing education platform for podiatrists, primarily in the area of musculoskeletal podiatry. And I've been a practicing podiatrist for around 15 years now, and for about 12 of those years I've had a special interest in musculoskeletal podiatry and physical rehabilitation of more chronic and complex presentations. And so I'm just going to throw over to Kirsty from the Lifting Pod. And Kirsty, can you introduce yourself?
No worries. Thanks, Felicia. So yes, I'm Kirsty. I'm from the Lifting Pod on my Instagram link, but I also am the director of Imperial Podiatry in Queensland. So we're just a mobile podiatry home visit service, delivering all aspects of podiatry. I guess, real passion for me to go into podiatry was just due to the fact that I love sport, I love exercise, and I have a history in track and field. Also just love the fact that we can take away or assist with pain relief, and that's the main motive for, I suppose, my treatment pathways, and working together with clients to be able to give them a better quality of life. And podiatry is just so much more than what meets the eye. It's not just, cutting toenails. And I think more and more people are becoming aware of the fact that we do actually treat from, the hips all the way to the toes, and it's so complex. So not one size fits all, but hoping today we can get some that misinformation out of the way. So yeah, thanks for having me.
No, it's all right. So I'm Aaron Wilson. The reason why my Instagram is Aaron Wilson Rehab. So not only am I a podiatrist, I'm studying physiotherapy as well as postgraduate, and hence why the name Rehab rather than Aaron Wilson Pod, because it didn't seem right to then have to change it later. And yeah, as you can tell by the rehab, my special interest is rehabilitation, MSK injuries from acute to chronic. So I'm based out in Sync Health, just a clinic out of Marrickville. We're predominantly working in sports injuries. We do general everything, and multidisciplinary as well with physios and EPs. And yeah, as well, just consult online through Instagram in between making memes, if you're aware of those. And yeah, personal background, haven't done anything too amazing, unlike Kirsty. I did play rugby league pretty much all my life, was lucky enough to represent the West Tigers in their lower grades. And now I'm just the guy who could have made it if I wasn't injured. So yeah.
I'm so excited to have. Thanks, Aaron and Kirsty. I'm very excited to have both of you guys here because, Aaron with his interest and history with football, Kirsty with her history with competitive track. I have a history of just being the perpetually injured runner. So haven't competed in anything amazingly on a competitive level, but distance running is kind of my jam that I've discovered over the last few years, and it's something that I quite often injured with, but it's not usually related to training errors, which at some stage we will discuss. It's usually my lack of spatial awareness and just being unlucky in the house that causes my injuries that I have to rehabilitate myself from. Now, the whole purpose why we've all come together is essentially we're forming what we call Foot Pain Explained. So it's not just for health practitioners, but it's also for the general public, because all three of us have quite a large presence on social media with all of the information that we're sharing and what our platforms are aiming and hoping to achieve. And like anyone who's on social media, yes, it's a great avenue to access information, but with the increasing presence of social media and how much people are utilizing it, there is also an immense amount of misinformation that gets shared on there, whether or not it's intentional, so people are just sharing their biased opinions, or it's just people or practitioners that just maybe aren't up to date with where the latest evidence sits. So the whole purpose of this project that we've come together to create is basically to take some of the misinformation that we see popping up on social media, breaking down why it may not be as accurate as it's portrayed, and then coming up with the actual evidence that supports our arguments and the reasoning why we're disagreeing with what's happening on social media. So just a caveat to this, if we do talk about specific posts, we're not attacking or trying to discredit individual people or practitioners. It's the information that we're discussing. It's nothing to do with the individual themselves. And well, there's maybe the odd one or two people that I'm not a huge fan of, because I do think that they have a little bit of a malignant interest in what they're sharing. But for the most part, whatever we're discussing, it is purely from an educational standpoint. It's not an aggressive take on any human that exists. We're just here to try and help people help people. So the topics that we're going to be discussing today is, we've all picked our latest gripe for the week from whatever's popped up on our own social media feeds. And we're talking about the dirty word that is pronation. And then we're also going to be talking about pronation, footwear, and its relationship to bunion development. And then I'll also be throwing in my 2 cents worth as far as a couple of recent posts that I've seen from certain bigger influencers regarding some pretty heavy duty misinformation regarding footwear and some of the pathologies that they can contribute to. So talking about pronation, I'm going to throw to Aaron first. Give us a little bit of a rundown as far as your weekly gripe for the Sunday roast.
Yeah, so I think it's even fair to say it's my however long many years I did podiatry for gripe was introducing pronation. So everyone knows it. What we think of it is probably different to what it really is, or at least I guess then you could say in my opinion, because people tend to have a different opinion. But one of the first things I taught with gait is the foot hits the ground. It's got a nice high arch. Actually, I'll get my foot out. It's got a nice high arch. It's called supination. It flattens, it's called pronation, then it supinates again as we walk off. And for some reason, and I'm not sure if you guys have the same experience with uni, I think I was about 2nd or 3rd year where apparently that stopped happening. You just hit the ground like that and plod along, and any deviation of that was bad. And that's where the dreaded word overpronation seemed to come from. And everyone likes to say it's bad, leads to injuries. And I've yet to come across a well enough argument where I believe that. And yeah, like that's essentially where the gripe is. So I guess you want me to just keep running with it?
It's, well, I can, so we've, all three of us have slightly different levels of experience. So I'm the grandma of the group as far as how long I've been practicing for. But I can very much say, so when we went through university, even then, so that was, what, 2004 I started studying. So nigh on 20 years, which is terrifying. But yeah, pronation was still considered quite a dirty word then. So too much pronation was bad. And that was back in the era where, especially with footwear, the aim of footwear was to be really supportive and to stop overpronation or hyperpronation. And what I've seen very much in sort of the last 2 decades of podiatric practice and studying is, yeah, there's more and more evidence that's coming out. So lower quality studies, higher quality studies, but all of this research is coming out that consistently shows that pronation is sometimes correlated with the presence of some injuries, but in a lot of injuries, it's not causative. So what that means is basically, yes, some people that sustain these types of injuries, they do pronate, but researchers can't find the link because there likely isn't one. There's so many other factors that feed into it. There isn't a direct link between that person overpronating or hyperpronating and that causing their injury. And that's where another issue comes from, is hyperpronation and overpronation technically don't exist because we can't quantify it. So if we can't measure how much is too much of something, then it just, the limit does not exist. So basically with that, so I might pronate 2 degrees, but for me in my movement pattern, that 2 degrees might upset things, but there's probably other things that are feeding into it. But for Aaron, he might pronate 25 degrees and not have an issue. So it's very much something that is easily blamed for being a causative mechanism for pathology and injury. And oftentimes that's what practitioners, and it's not just podiatrists, like physios or any other health practitioner, doctors as well, they might go, it's because you're pronating too much that it's causing the problem. Very rarely is that the actual problem. So Aaron, I'll throw back to you, or Kirsty, if you have anything that you want to throw into that with your experience.
Yeah, I suppose going through uni, I think you're sort of taught in a little bit of this, I don't know, tunnel vision phase of the paradigms. And that's kind of how, as your brain, you know, as you learn as a health professional, where you get your resources from. So I don't know if you guys remember, you know, the root paradigm, or, you know, Kirby's, you know, subtalar joint access and things like that. But I think that's where it kind of all like took off. And I think that would have been like, you know, the 1980s and then the 2000s, of where, you know, you got a neutral sort of axis. But what is neutral? Because that is so variable amongst, you know, populations. And then I suppose the question is, what is a pronated foot type? Because for someone, that could be a really comfortable position for them. So then I would say that is a neutral position because it's comfortable. And it's not, as you said, it's just a factor in their, you know, makeup. It's not necessarily a bad thing. So I think there's just a lot of variance in when the word pronation comes about. It's not an isolated, you know, diagnosis or anything like that. It's so many different, I suppose, avenues we can go down in regards to pronation. But for me, being someone who is, you know, a pronated foot type, as a kid, I wore orthotics, and as a podiatrist now, I don't wear orthotics because I've learned to, you know, build up those, I suppose, muscles in the layman's terms to, you know, perform at my best. And when I do need, you know, extra support, that's where, you know, Aaron comes in with his awesome, you know, sock rehab and things like that, where, you know, you've got exercises that you can help rather than just putting in something to, you know, cure it, I suppose. But yeah, it's a bit of a tricky one because a lot of people will look at it and want to fix it, but it's not about being fixed. It's about just an observation rather than a diagnosis, I suppose. So yeah.
And that's a really good point that you made, as far as it's an observation, not a diagnosis. And that's one thing that I'm sure both of you will agree on. And it's one thing that shits me to tears is pronation isn't a diagnosis, where if someone's told that you pronate, that's your pathology, that's your problem. Like, pronation is a movement, it's not a diagnosis. So like, we don't tell someone that you supinate and that's the name of an injury, or you abduct and that's the name of an injury. Like, it's literally just a description of movement. So Aaron, just because you're the biomech man and you've got the foot sitting with you, can you explain probably a little bit more about why it's actually necessary for gait, and like walking gait and running gait?
Yeah, so my big thing with that comes from, so if you look through research, especially when they use force plate and data like that with the running, you actually see that most of the force produced into the ground is when the foot's in a pronated position. And now that's my first thing that turned my head in early years of uni as well, because we're taught, well, the foot's a mobile adapter, it hits the ground, goes floppy, therefore if we hit a rock, we don't stumble. And then the foot goes nice and rigid to push off the ground. But even when you think of other muscle groups, you know, if you're doing a bicep curl, the hardest part of the work is probably at the start or at the middle. When you're at the top and it's in its shortened position, nothing's really going on. You're just kind of there. And it's the same story with the foot. The foot hits the ground. It's, you know, it's generally a bit rigid. And even if it's flat, it's still quite rigid. People neglect that. There's a lot of bones in here that lock up regardless of whether it's flat, high arched. And when you hit, you know, with gravity, with force, as we're trying to propel, it hits the ground and it's got to continue to push into the ground, regardless, again, whether, like I said, if it's flat. And it's that period of time where we're pushing into the ground. And if you want to get flashy and start throwing out Newtonian laws, like number 3, every action is equal and opposite reaction. To be able to get off the ground, you got to push a lot harder than you're coming into the ground. So therefore, the forces from the ground push you forward. And in doing so, that generally happens when you're in pronated position, because that's the point in time where your foot is no longer elongating and we're starting to get that stretch contraction and that elastic recoil. And the simplest way to even just physically view it is if you try to jump as high as you could with allowing, you know, in the most natural position, you'll probably find you pronate, you internally rotate, something to that degree. Then if you try to externally rotate everything, really grip your feet out, like twist your feet, have that high arch that we're traditionally led to believe is perfect, and try to jump as well, you probably find it feels like shit and you don't get really high. And somewhere along the way, it still hasn't seemed to translate to that because, like we already spoke about, yeah, everyone just sees this foot from behind doing that and go, oh, that's bad, that hurts. And yeah, you just watch any marathon runner, any sprinter, and their foot does that, and no one bats an eye. And I like what you said about, like, it's highlighting it is a movement, and you know, you could use the same premise for every other movement in the body, and it just doesn't make sense. You know, if someone started, you know, walked a certain way, if you started saying, oh, they're an internal rotator, probably go, okay, well, what does that mean? But then someone goes, oh, you're a pronator, and it's yikes, that's an issue.
Yeah, it's all of a sudden associated with all of these bad terms. And that probably, this is slightly segueing from what we were planning on talking about, but it still fits the narrative, is like when we see, there's two pictures in particular that I hate, and they're both related to each other. So it's often images people use to advertise orthoses and whatnot, where you've got one foot that's just a cartoon foot, or it might be a real human foot. By the way, it's a picture of the back of the foot, and it looks like it's collapsing in quite a lot and it's overpronating. And then they have, and it's got the sort of bendy line saying, oh, and it's usually a red line because red's bad, right? So someone's just standing naturally, and then they've got this foot that's rolling in. And then the next photo was them standing on an orthotic device, and there's a nice vertical green line that's there. And that's often used to, I think originally when those images were first developed, it was probably just a way of sort of trying to communicate something complex quite simply, but it's just been bastardized to the point where it has fed into this narrative that pronation's bad and you need to have this vertical or rectus or supinated looking and functioning foot to function okay, which isn't accurate. And then if we zoom out from that, the picture that follows on from that usually starts at the feet, but there might be one side of the body that it's all nice and straight and it's all straight lines, and then the opposite side where we've got all of our red lines, and you've got a foot that's rolling in, a knee that's internally rotating, a hip that's dropped, a shoulder that's dropped. And that's often used as a, yes, you need to have an orthotic to give you this vertical posture. And it just, so many things. And we'll talk about knees and internal rotation another day, because it's something I know you two know a significant amount about between sports and powerlifting, how much knee valgus and its relationship to movement. Yeah, we'll get into that another day. But have you guys because I've seen those pictures a billion times in the however long I've been practicing for. Are they two pictures that you guys see quite regularly popping up?
Yeah, quite a lot. And yeah, it's funny because what we fail to realize when we look at them, because on paper, yeah, it looks cute and looks great. Like, okay, red, bad, green, good, nice little fix. But the whole point of, you know, assessing like gait and foot and all things like that, we're moving, and and that's my one thing I don't really follow on to is, yeah, postural assessment, because posture is only as good as how you've held them, how you've stopped them. So if I look at your foot, leg, ankle, whatever it is, I'm seeing it right now in this exact moment. The moment you take a step, whatever I've just looked at, assessed, is out the window, because it won't come back, because that's been left there behind. And the same can be done with any of those photos. You know, oh, look, you're red here because, you know, you're twisted in. As soon as I take that next step, or if I position you slightly different, the whole thing changes. And I can probably guarantee for most people, you can get that perfect green line anyway. And that's actually something I want to ask, since you've already said it. So Kirsty, you said you've got a bit of a more typically pronated foot position, and you had orthotics as a kid. Did it fix it?
Funnily enough, it wasn't even for my my foot. It was actually for my knee at the time. And from memory, it's hard to diagnose myself because it was when I was about 10 years old. So I'm assuming I had some sort of, I don't know, Osgood Schlatter's or something like that, that age bracket of osteochondrosis. I'm not 100% sure, but I do remember it feeling better. But at the same time, I was out of them within probably 2 to 3 years. So, what's to say it was the orthotic, or was it to say I grew through puberty and built that strength myself? It's a debate probably for another day, but at the same time, exactly right though. A lot of the time you just go, oh, pronated, here's a pair of orthotics.
Sorry, is your foot still the similar position?
Probably worse. Yep, probably more internally rotated.
And there's just one point I wanted to put on with that. So none of what we're saying is orthoses are bad. So orthoses, they certainly do have a role as far as altering load. So Kirsty, even for you, it may have at that point in time been what you needed to change the loading mechanics of the foot when you were walking or running. So I think the point that we're all sort of trying to make, because none of us are anti-orthoses, we all prescribe orthoses. We're just all, I feel, very considered in our prescription of orthotic devices. So I think what we're trying to probably call more attention to is, one, the misinformation surrounding pronation, and then how by health practitioners across the board, and not just health practitioners, like even footwear stores, for example, because some of them do like to upsell inner soles as well. So it's just the pronation, the misinformation surrounding it, what it is, what it's bad for, what it's good for. And then also how very easy it is to blame that and then use that as justification for prescribing an orthotic device. So yeah, I feel that we're probably all on the same page that yes, there is a role for orthoses. And sometimes what we're doing is trying, when we're prescribing an orthotic device, to control, or not, well, we can't really control, to alter some of the forces, which may be pronatory related forces going through a foot for specific injury management scenarios. But yeah, we're all on the same page as far as orthoses aren't bad, and pronation sometimes is something that we do address in a script.
And even then, like to back to what I was kind of saying before, like when you look at it from the position of forces and what we're doing there, rather than what the positions are, you'll come across that, because the commonly question then I get thrown at in disagreement when I say something bad is they go, well, this person has pain and they pronate, and they get pain worse when they pronate, so therefore pronation is the problem. And because if in their opinion they stop it, change it, whatever, and they get results, they fixed it. And like talking about it before, it's the position where most force is generated into the ground. It's the position where most tendons in the foot are at their most elongated position functionally in gait. So there's a lot of force, there's a lot of length. And, when you look at other injuries in muscles, we know muscles tend to get injured more at that lengthened position. And they also tend to get injured when there's more force put through them, because there's a demand that needs to be reached and in a lot of cases exceeded. And that's kind of how, sometimes with it, you don't have to throw the baby out the bathwater and change the whole dynamic by saying, well, pronation's now good, which it is. You just kind of got to like tinker with the lens a bit, because you can make modifications to that, but we're not fixing them or reducing the stress because we've just simply changed the position. We're simply just changing the amount of force that has to be applied to get the outcome, which is essentially just load management, just with flashier words.
Yep, I very much agree with that. And it so just because we'll jump on to the next topic in a minute, but just sort of expanding a little bit on what Aaron said. So yeah, when people are in that sort of maximally pronated or lengthened position, like there is a purpose for that, because our muscle tendon units, their job, how it works in gait, is to store and release elastic strain energy, which is the same with the plantar fascia. So we need to have load applied into the tissue. So if you just think of it like an elastic band, so it's got to be applied in there to get that stretch so it can recoil to help propel us forward. So that's the whole purpose of it. So if you're trying to eliminate something that you actually need to have an efficient walking or running gait, then you're not going to have an efficient walking or running gait. So sometimes it's just modifying the load that's happening into a tissue to a point that we can calm it down so the body can adapt, so you can keep moving forward. Pardon the pun, but
yeah, 100%. I think I learned that quite early on, I suppose, at uni, when I think we were on a placement once, and a physio I sat in with was like, okay, what do you see the difference between this sort of standing foot posture and then, you know, when they're walking? And the answer to me was very simple. I was like, they're completely different. And he's like, exactly. He's like, you can't take, you know, that standing posture, you know, what we're talking about, that static, you know, SPI, you know, your foot posture index that, you know, everyone loves referring to, and then say that they've got that highly pronated foot, because when they're in, you know, gait and, you know, in watching their mechanics and in analyzing those three sort of phases, then it looks completely different. And I don't know about you guys, but I've seen a lot of patients that, you know, statically they look pronated, but then when they walk, they look more supinated. So it can be completely different functionally. So I suppose it's like form versus function, and not trying to treat the, you know, the presentation on a static level, because do we stand still for our whole life? No, we walk around and, you know, we sit down and we get back up, and going from a seated position even just to standing, you know, we need those muscles. And I think I've said before to Aaron as well in one of his posts around our anatomy, like the foot is so, I don't know, it's constructed and engineered so specifically that, you know, we have that certain amount of ligaments on that medial aspect for a reason, and that is to pronate. So you've got to have, you know, a variable in there where I suppose it's hard because you have a spectrum, I suppose, of movement, and maybe that's why we have these terms of overpronation and whatnot, because people go, oh, they've kind of fallen out of that area, or they're an anomaly or whatever it may be, and so they're classified as different or abnormal. But realistically, who are we comparing it to? Are we comparing it to the patient, or are we comparing it to a population? So I suppose just looking at the patient as a whole, and not taking one factor and saying that that's what's wrong with them, because yeah, it's definitely not that way inclined.
Yeah, definitely. And it's very much like, is it the fact that someone's pronating, or is it the fact that they just normally overpronate? And I'm just using that in quotation marks. So do they overpronate and that's the problem, or is it the fact that they've increased their running mileage by 20 kilometers in 1 week? Like, is it the fact that they have diabetes mellitus, it's not well controlled, that's contributing to the development of their musculoskeletal pathology? There's so many other factors that feed in there that once you combine them all together, some may play a part, but then they may not. But moving on from that, because I'm sure in future episodes we're going to do pronation time and time and time again, because it's just the thing that will never die. But I do want to move on to probably the next topic, because they do go hand in hand. So if we've got someone who's pronating, and oftentimes there's two things that are used by health practitioners to try and stop this overpronation or hyperpronation, and that is orthoses and footwear. But there's another little bit of misinformation that scoots out and about regarding footwear and also pronation and also orthoses, and that is bunions. So what I kind of want to get Kirsty to start talking about is just probably footwear and the fact that poor fitting shoes is the be all and end all as far as causing bunions.
Yeah, for sure. I think it's definitely a latest craze at the moment on social media. You know, you see
yes,
a shoe and you see your foot, and then you see below it another shoe and another foot. And you look at it, and they're obviously two completely different feet from different people to start with. So it's not a good comparison, but just looking at the shape of a foot and thinking if you put something into it that you're going to get the same shape. I suppose Aaron had an awesome meme a while back about a cone head, which I found absolutely hilarious. Of, you know, if you put a witch's hat on your head, and then you come out and you've got this like mega mind head or whatever. So like that's kind of the concept how I see shoes in a way. It's like as if, you know, if you put your foot inside this shoe, it's going to come out looking exactly like that. And The average person probably, I suppose, average non-sedentary person does, approximately 10,000 steps a day. So the forces going through the foot inside those shoes, yes, are definitely great, but is it to the extent where your foot changes shape? And I suppose that's where bunions come into play, because there's a big area around the idea that the main cause, and like highlight on the word cause, of bunions is from poorly or incorrectly fitted shoes. So I think it definitely comes down to the fact that I'm not saying that this is not a thing, because I've definitely seen a fair share of feet that haven't been fitted into shoes and have those, lesser toe deformities, the hammer toes, your mallet toes, you've got corns and callus, and that's clearly an indication of the friction in the shoe. But I suppose for me, are we looking at just the extrinsic sort of factors, which is, the environment, the shoe, what type of shoe, what activity? As I was chatting about before, are we getting to know the client and the patient and what they are actually doing in the shoes? Because that's a big indicator of, I suppose, the outcome. For example, myself wearing a pair of spikes, for example, I need to wear a pair of spikes to run on the track to perform at my best, because it's just something that goes hand in hand with sprinting, and it's the grip and it's the start off on the blocks. It's a lot of things in relation to that activity, versus Aaron, grabbing a pair of footy boots, jumping out on the field. He needs to wear those shoes to do that sport. Otherwise, there's other factors that could come into play that we won't go into in terms of injury if he doesn't have that grip. Needless to say, I suppose, are those shoes marketed a certain way, maybe to look a bit slender or to look a bit sleek? Then yes, definitely. And there's definitely a negative impact to that. But I would dare to say that it's not necessarily always the shoe that causes the bunions. And that's probably where it'll fold into the next point of the intrinsic properties of a bunion. And I'm sure you guys all know and went through all that at uni of, your hallux abductor valgus, your HAV, which is a terminology we use quite a lot. And the intrinsic sort of properties where aren't as heavily weighed at the moment, which I think a lot of people are not necessarily disregarding, but aren't shining a light on, which are just as important as the ill-fitted footwear. So, things such as that sort of short second metatarsal, or that longer first ray, and those little things that can actually cause that lateral deviation, or, where the sesamoids are. Sorry, using my hand because I don't have a foot. So, where the sesamoids are. And, displacement of them, or are the sesamoids naturally in that position, and therefore there is a genetic predisposition, other things as well. So it's not always a shoe that is the main factor, but the actual makeup of the individual. Probably could go on, but I would dare to say that 70% of HAV comes from that genetic component. So I suppose definitely need a lot more education around shoes and how to fit them, because it's obviously not just the width of a shoe that can cause a bunion, but also the length and the depth. And, there's quite a few factors of a shoe that need to be considered. But I don't know, I think there's a little bit of marketing going on around, if you put your foot into this shoe, it will give you this. And then the turn side to that is also that the sort of more flexible barefoot shoes that are coming out with the wider toe boxes and things like that to allow for splay. But then again, is it the shoe, or is it the fact that the foot already has all these factors that are going to, predispose them to have that bunion? And what can we do about it before it gets to that point? Because I don't know about you guys, but I haven't seen a huge amount of bunions in like teenagers. I've seen a fair amount, but most of the bunions I see are in, that geriatric sort of population, or 40 to 50s, and they usually say, my mum has it, or my grandma has it, or whatever it may be. So yeah, I'll flick to you guys and see what your sort of perception is on it and what you've experienced, I suppose.
Yep, no, that was great. Thanks, Kirsty. Aaron, I'll get you to launch into, because I know that you've put a couple of memes and bits and bobs up in recent times.
Yeah, so it's interesting at the end about the teenager bit, because so this isn't clinical experience, this one. This is just a old friend of mine. They had bunions since they were a child, and were on all the like flashy footwear, wide, stretchy, whatever it is to accommodate it. And people love to go, well, if we look at primitive ages, they didn't have bunions. Or if we look at us now, we have bunions and we were older, and it's because of the shoes. But people still get them when they're young. And it's funny because when you look at the research, actually, the research is poor in that the correlation is with the width. But there's actually somewhat evidence that suggests the length is important. And most of the research we do have that links footwear and bunions all talk about the length was the significant factor, not the width, which is just a funny little bit there. But yeah, my big thing is with the shoes, they can be important, and I don't discredit that, but people also overly estimate their impact, and the ones that do genuinely have an effect because of the footwear really underestimate their foot size. So this is something I've had a fair bit clinically.
Yep.
And it was funny because as a new grad, it was my very first bio foot pain, however you want to address it, patient. And it was pediatric, and they came in, and every test I did, they told me everywhere in their foot hurts. And I was just like, oh shit, what do I do? All right, back to basics, do all your tests. Not a single test brought on pain. And I'm going, shit, like, what am I supposed to do? What do I tell this poor kid who's apparently in a lot of pain all the time? And then just through starting to talk to him and, getting a bit of suggestive history, he turns around and says, oh, I only get the pain when I start to play soccer at school. And I'm like, okay, so what do you do at soccer at school? And he goes, oh, I put on my soccer boots. I go, okay. Do you have your soccer boots with you? Like, your sizes or whatever? And he's like, oh yeah, I do. And he grabs them out, and they're a size 8. And then I go, well, what's your regular shoes like? What are they looking like? And they're a size 10. So out comes the Brannick device, and yeah, he's about a 9.5, so he gets the size 10. But his mum hadn't replaced the shoes, and sorry to if that mum ever hears this, didn't get the new soccer boots in time. And so every time he put them on, yeah, he had the pain because he was wearing shoes extremely small. And I mean, I know that firsthand. I recently went to the snow and didn't want to pay the rental gear, so I got some from a friend. And I was wondering why they were snug, and I got told they're uncomfortable. At the end of the trip, like, my foot was killing me. And it wasn't until I had to get a replacement because part of my board broke that they measured me up. They're like, yeah, what size boot are you? So for reference, I'm a size 13 shoe, and the boots I had were size 10.
Oof.
It wasn't fun. And those it's those cases, yeah, where the footwear can be a factor. And people will always bring up, they'll go, what about Chinese bindings back decades ago? They got them at birth. You got to consider when they had no bone, so it's floppy. You can move them whichever which way. But that's the other thing. They were significantly smaller, and they were rigid, stiff shoes that didn't provide that. Now, if anyone's ever worn a Nike, they're not that rigid. They're not that hard to push through. The amount of times I've seen people with worn out, just regular joggers, and they've got holes that are stretched. There's movement in those. Now, if they were 4 sizes smaller and they still had that bunion, I'd go, look, maybe it didn't help. But there's a lot more bigger, lower hanging fruits to deal with than the shoes. And then when you address the shoes, if that was the issue, then you probably would have seen a lot better outcomes. We probably also wouldn't see these shoes anymore because everyone hates bunions. Like, women's footwear would not have pointed toe shoes or slimmer shoes if the very thing that every female with a bunion comes into clinic complaining about is having one. There's no way these shoes would still be around. No one would want to buy them.
Yep, and I like that you pointed out that there's probably a little bit more weight behind the length of a shoe as opposed to the width of a shoe. And yeah, because oftentimes, again, same with pronation, same as footwear, it's very easy to blame that one factor. But one thing that we need to consider, and this is one thing that I do feel that health practitioners, so there's kind of two types of practitioners that exist. There's the ones that take on that more authoritative stance with a patient. I'm the professional, you have to do this, 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 and this, and there's no negotiation. And then there's other practitioners that it's that more shared decision making, because yes, for some people, they come in like both of you were talking about, with people sort of selecting what shoes that they want to wear. Not everyone's going to change their footwear because you've got some influencer going, your narrow shoes are going to cause bunions, which one, it's bullshit. But two, if you're someone that you do have a little bit of a bunion that's developed, you're not getting any symptoms, it's not affecting any form of your function, you're not worried about how it looks, you just know that you've got a forefoot that's a little bit wider and a toe that scoots in a little bit. If it doesn't impact you at all, if you can still wear what you want to wear and there's no issue, then to me as a practitioner, that's not an issue. Like, where footwear comes into play most of the time in my clinical practice is length is something that very much I feel is quite important, and that's addressed. But width with shoes, if someone is symptomatic, then yes, we'll discuss widths in shoes, whether or not it's symptomatic as far as like musculoskeletal pain, or if they're getting callus or areas of rubbing, blisters, irritation, things like that. But it's very much my approach is, if it's not broke, we don't need to fix it, because again, like pronation, footwear is oftentimes blamed for something that it's not necessarily causing. So if it's clearly identified that footwear is a contributing factor to whatever the person's problem is, then yes, I'll address it. But I don't think we need to hold a gun to the head of footwear and just go, you are the cause of all of the bunions that have ever existed. So there were two, when we were discussing before we came on, there were two papers that Kirsty, you referred to, and one of them was quite recent. So I think one was like a 2012, one was a 2020 paper, that talking about the role of footwear in the development of hallux valgus, or layman's terms, bunions. Can you just give us a little bit of a run, because they're the papers that you came in with, give us a little bit of a rundown as far as what they found in relation to footwear and the development of bunions.
Yeah, so it's quite hard for them to determine like if it was specifically footwear. So the one, I don't know if it was the 2012 one with Nix or not, but yeah, it pretty much just spoke about how it's actually more to do with the genetics component of, I suppose, that longer first metatarsal rather than the shoes. And the population they had as well was quite a few women, to be honest. So they probably had a little bit more of a smaller case study than what was needed. So there's obviously all those limitations there, but the cross section between whether it was shoes that caused it or more like genetic component, it was quite hard for them to determine, which for me is still a successful study, because it just rules out the fact that it's not one way or the other, if that makes sense. It's just a few clinical factors. So it's not just, I guess, the first ray, or it's not just footwear. It'll be, as you said, it's, a few underlying features that the patient has. So that's kind of what they came across, and it was not as conclusive around, footwear being the complete cause, I should say, of HAV. So, but then again, I think there was one article that I've read recently. I think it was a little bit further ago. I'll just have a look. Just made a note. Sorry. Doing NDIS stuff today has really put all the articles in the back of my head, but I did write a few notes. Yeah, there was one interesting thing that I wanted to say. Oh, yes, they spoke about, it's pretty interesting because it just spoke about how a lot of people were saying, you know, back in the day when people had to wear like high-heeled shoes, I suppose it was a little bit more of that sexist vibe of, you know, you have to be done up. And there's a lot of people saying, you know, when I was 21, this is why my feet are like this now. I don't know if you've heard that phrase before, but it said that there was no correlation to do with a high-heeled sort of pointy shoe and the outcome of the patient having a bunion, which I found really interesting. I was like, I don't know, for me, I did sort of feel that pointy shoes, you know, as I was saying before, the pointier the shoe, you know, your toes do have to like be encapsulated by that. But yeah, there was no correlation whatsoever. So I found that really interesting. I think that was a bit of an older article though. I think it was like 1985. So the most recent one's probably a little bit better.
They're all good point. And I think it's just really highlighting the same with pronation. It's like keep going back and forth because they are quite interrelated and very similar results, where for one person, footwear may be a potential contributing factor or aggravating factor once it's thrown in with their pre-existing other factors that exist. But again, footwear's not the little evil monkey that's causing all the bunions for everyone. Aaron, have you come across any papers different to what Kirsty was speaking to in regards to footwear and bunions?
No, look, I've come across the one she's talking about, especially the next one. So I've got that one kind of is almost etched into my memory.
Yeah.
But even then, a lot of the papers that do talk about, there is a connection, they're very poorly done. And if I had to name and shame him, it comes from, I don't know what country he is, but the researcher Menz, who's pretty prominent when it comes to just foot-related research. And the thing with these, there's a lot of good work. So it's not me saying, throw it all out, burn it to the ground. It's not that. A lot of it is survey studies. And again, not saying that they're bad, but there's a time and place. The ones in bunions in particular. So there was one they had about, it was 2002, they had about 1,700, I believe, surveillance. And then they talked about, so they were all women, they all were in their 40s and up. And they talked about, okay, well, what footwear do you have? And they gave them images. Now the images started at, you know, a normal, like a women's pointy shoe, to then a slightly pointier, to then a really pointier. And then it was a slight height to the middle between a heel and a ballet flat, and then the heel. So straight away, already, if women wear joggers, if women wear thongs, whatever, that was already excluded. Couldn't talk about it. And that was what they found. They went, well, all these people that have bunions, they all showed that they had these shoes. But then if you also look at it, well, because they had no other option to pick, so they picked the most close to it. And even then, a lot of these people were 67 years old, and they're asking them to remember 40 years ago, what shoes did you wear the most? And then you got to think, like, as well, like, these people probably assume that heels or the tight shoes probably cause their bunions. So they probably looked down their feet and went, yeah, I probably did wear those shoes then, yeah.
Yeah, so the validity can be seriously questioned. So with the next paper that we're talking about, once it's on the social platforms and we throw it on YouTube, I will put the link to it because it is a free article and it's actually a systematic review. So when people do systematic reviews, they basically collate a huge amount, well, as much as they can, but a huge amount of information and go through all of that information and sort of identify the trends with it. So with the next paper, it's titled "The Characteristics of Foot Structure and Footwear Associated with Hallux Valgus, a Systematic Review." And it was published in 2012. And I'll just read the conclusion for it because I do think it's a really good paper and it highlights something that, well, Aaron was talking about a retrospective study, but self-reported surveys, but I'll read the conclusion, then I'll explain something. So the conclusion was, although conclusions regarding causality cannot be made from cross-sectional studies, that's what I'll expand on, this systematic review highlights important factors to monitor in HAV assessment and management. Further studies with rigorous methodology are warranted to investigate clinical factors associated with HAV. Now, the things that they were talking about with this were the significant factors that were discussed that had more so to do with the development of HAV were greater first intermetatarsal angle, a longer first metatarsal, a round first metatarsal head, and lateral sesamoid displacement. And then the results for the clinical factors that weren't conclusive as far as their relationship to the development of bunions was the mobility of the first ray, pes planus, or having that sort of flatter foot type or pronated foot type, and footwear. So footwear and a flat foot are two things that even 10 years ago, there wasn't conclusive evidence, and it hasn't actually changed really at all since then. There's not conclusive evidence that either of those factors are the main driving force behind someone developing a bunion. Now, when we're talking about cross-sectional studies that they mentioned in the conclusion, so cross-sectional studies, they don't look at people before they've started using something. It's a cross-section. So they just get people where they are at that point in time and see what's similar between it all. And so when it's a cross-sectional study, you can identify correlations. So someone wearing this type of shoe, or someone that's got this structure, or doing this activity, you can't determine from those types of studies what has caused something, because you weren't there before that activity or footwear or any intervention has come into play. So that's what's really interesting. So I just thought I'd discuss those findings from the paper. It's a really good paper. Like I said, I'll link to it. Now, this, I do want to scoot on to both of those things. So when we're talking about the results of this systematic review, that was a decade ago, that the results still haven't changed with further publications. As far as pes planus foot type and footwear not being a clearly identifiable causative factor for the development of bunions, there's one social media presence that just recently has just developed a significant foot fetish for, well, we know why it's happened, because if you're going to create and develop and sell your own shoe, then yes, you do want to talk about footwear a little bit, don't you? But one of the claims is that having a narrow lifting shoe, one, is a cause of bunions, but two, the post that really drove me mental was having a narrow shoe, putting pressure on your big toe, being a cause of plantar fasciitis. So have you guys seen this post?
Yeah, I think if you go far enough through my page, there's me, my head in front of the identical post that was, 6 months ago or whatever, however long ago. Is quite a lot, quite a common occurrence, especially the study I know we're about to talk about.
Okay, so there's a number of problems that I have with this study. So talking about 4 foot toe box width and it being the cause of plantar fasciitis, the premise behind this post, or the message that was being delivered, was essentially the pressure on the big toe was decreasing the blood flow in the plantar fascia that led to the development of it. So from my memory, that was the main point that was discussed in this just beautiful piece of misinformation. Aaron, were there any other bits and pieces that were discussed in that, or have I summarized what he was talking about quite well? And I know that you're quite familiar with the study that was referenced in this. So can you just give us a little bit more information on this beautiful bit of garbage that we're discussing?
Yeah, so it is pretty much, so I think, yeah, you nailed it on the head, that the post was about, well, like, if your foot's like this and this is, the ideal, well, your shoes do that, take that big toe all the way across. And because of this one study, now it didn't go into the study, it didn't go into the details or anything. It was just the study. The conclusion was, well, doing that stretches this muscle called the abductor hallucis that runs across the side of the foot and a bit of the underside and compresses on one of the arteries to the foot. And so there's quite a lot of issues. One, with the theory behind that, there's a lot of holes you can put in before you even have to consider the research, but then the research itself. So one of the holes being muscle flow to, blood flow to muscles decreases, the arterial, I'm trying to word it. The blood flow present within arteries decreases as it approaches muscles in a lengthened position, because as they contract through the skeletal muscle pumps, blood is then perfused back out of the muscles back towards the heart, and that's how you get contraction and shortening of muscles. So that alone, you would expect to see that in every muscle. If you lengthened it, the surrounding blood supplies would be somewhat smaller, because the volume of blood sits around somewhere within the blood, the actual tissue. And when we think of the pump we get following exercise, it works on that premise. The other thing being, if that was the case, then that muscle probably should be, it should not exist then. If you think that its action, anytime you stretch it, it stops all blood flow going to the foot. Sounds like quite a problem. And then when you think as well, it's not a problem, because we all have feet and we don't all walk around with gangrene. And that's the other thing. There's multiple arteries to the foot. They measured one. They didn't measure the later branches. They didn't measure the earlier branches. They measured it at one point. So yeah, before you even look into the study, there's a lot of holes to the conclusion jump from, this study said if I push my big toe this way, this muscle compresses an artery, therefore no blood, therefore pain, shoes bad. There's a lot of little hurdles to get before you can even then get to that. And then when you look at the study, it's like looking at the colander. There's holes everywhere.
Yeah, it's one of those beautiful bits of garbage that, like, you can't polish this turd. There's just absolutely nothing that is accurate about it. So like the theory behind it, it just doesn't follow the laws of anatomy and physiology or gravity, or, like, I'm not a vascular specialist, but also just how our vascular system works. Like, there is nothing about it that's accurate. And then if we look at the risk factors for the development of plantar fasciitis or plantar fasciopathy, there's so many intrinsic and extrinsic risk factors, and for everyone it is very, very different. And footwear is one that, again, from cross-sectional studies like we were talking about earlier, is for some people, cross-sectional studies in relation to the development of plantar fasciitis or plantar fasciopathy has been identified, but the quality of those studies, again, is quite poor. And then the factors that determine if it's poor footwear has nothing to do with any pressure being placed on the big toe. It's more so to do with the height of the heel, the flexibility of the shoe, how much shoe there is. But that factor on its own isn't a factor. It's usually that combined with other factors like your occupation. How much time do you spend standing? How much time do you spend standing on hard floors? So if you're squatting in a shoe that is slightly narrow, it's not going to give you plantar fasciitis or plantar fasciopathy at all. And the mechanics of it don't marry up. So essentially the development of plantar fasciitis or plantar fasciopathy, it's a complex interplay of individual factors, and there's no sort of one definitive factor that has been identified to be a causative mechanism for one person. So even biomechanics, there's no definitive biomechanical measure that places someone at an increased risk of developing plantar fasciopathy. So if we look at, so a lot of the studies that they've looked at goes across a broad range of different people. So, and we will talk about plantar fasciopathy a few times in upcoming episodes, but just harping on the risk factors so I can poke some more holes in this colander dumpster fire that we're talking about is, so in overweight, so people with a higher BMI, overweight individuals, and also overweight individuals in an occupational setting, having a more positive foot posture index, so a flatter foot, is more of a risk factor. In athletic populations, so people that are performing, well, doing athletic, right, competitive runners essentially, so whether or not it's middle distance or long distance, the development of plantar fasciopathy is more so related to a higher arch foot posture and like a varus knee alignment. But that is in combination with wearing running spikes. So it's very much like we're talking about with the other topics that we've spoken about today, is it's the interplay of multiple factors that will potentially cause it for an individual, not a narrow bloody toe box. Putting pressure on your big toe is not going to cause plantar fasciitis. And that was one other thing that I wanted to poke holes in his argument about. So in the post was talking about how, yes, pressure on the big toe will cause this vascular occlusion. So you're not going to get blood supply to the area and it will cause plantar fasciitis. If we're talking about actual plantar fasciitis, where we've got inflammation, so if we do ultrasound studies where it's contrasted and you can, the Doppler ultrasound, there's actually an increased blood flow in someone that's suffering an acute bout of plantar fasciitis. So even that is contrary to what he's saying. So if you've got plantar fasciitis, according to this post, there's not blood supply there and it's causing it. But if you have true plantar fasciitis, when I say true, that's differentiating between plantar fasciitis and plantar fasciopathy. Again, we will unpack this another day. But true plantar fasciitis, you do actually have an increase in blood flow because there's more inflammation happening in the sheath and around the tissues. So one, footwear doesn't cause it. Two, you're not going to get gangrene. So just, I will finish my rant about that. But yeah, as far as risk factors and whatnot, have you guys ever come across anyone that's developed a gangrenous plantar fascia from wearing narrow toe box lifting shoes?
Negative.
I love that both
I
of you were just looking in shock.
So I've got, a bigger foot. I've got a wider foot. My lifters are like one of the most comfortable shoes I've ever worn. And even then, like, I'm not going to rip out the insole of it. I don't want to damage my shoes. But you just sit your foot on top of it. There's a lot of room when you properly fit your footwear. And, the common thing, and I try to educate as many people as I can about it, shoes have a width size. And if you're finding it is a bit snug, there's another width. You go up and you feel brand new whenever that is the issue still.
And there's also shoe stretchers that exist, which I bought my shoe stretcher. It was more for selfish reasons, but then because I do have quite a broad forefoot, and do have a little bit of a bunion and a tailor's bunion. I also don't have a flat foot. I've got a foot posture index that's just a mishmash of garbage. So I've got a high arch foot with a plantar flex first raise. So if we look at the back half of my foot, it appears like it's a high arch foot. And then if we go from the midfoot to the forefoot, it's like it's a flatter foot. So it's just a garbage foot. But yeah, I get the shoe stretcher in, can go into a normal width and it's comfortable. And the development of my bunions is not accelerating with wearing narrower shoes or anything like that. It's just doesn't cause me any pain. I can lift in, because I lift in, not that I've lifted for a while, I've become a bit more of a running wanker the last few years, but when I was squatting heavy, the Innovate fast lift shoes, I've still got my lifting shoes. They're quite narrow, but I'm not running in them. And yeah, I stretch them slightly around the first MTPJ, and I don't have plantar fasciitis. My bunion's not worsening from them, and it's not an issue.
It's all good. I like the point you made though about, I suppose, the origin and like the original, I suppose, pathogenesis of true plantar fasciitis. Like, you can even feel it in your clinical diagnosis of like the heat that sometimes is propelled from a foot, and you just know straight away the amount of blood flow that's there. So it just doesn't make know, it doesn't make any sense in my brain that it would be the opposite, complete opposite comparison of, you know, the gangrenous foot.
Yeah,
which, I don't know, just it's hard to puzzle together in my brain, but
so just
sorry,
insert,
you go.
I was gonna say, so a fun thing, so if you ever read the study, a third of the people involved actually got more blood flow to the foot and that artery when they did bring the toe over. So again,
that's interesting.
Oh my goodness.
I'm glad that we got to talk about that post today, because I've been just incensed just from the complete shittery that it was. And again, that's where it's, like I was saying right at the very start of the episode, like, I think some misinformation comes from like an innocent place where people just may not have updated their knowledge base in regards to literature, and they're still trying to do good. Where my problem with this, and quite a few of the foot fetish posts that come out from this particular account, what my problem is all of this shit was being splattered out on social media with, surprise, surprise, the launching of my own wide toe box lifting shoes. So my issue was, I feel that there was a monetary reason behind cherry picking misinformation. So it's essentially someone taking literature out of context and not sharing the full scope of what the information that they were drawing on, sharing that to, over the course of weeks and months, building a narrative as far as, this is bad, this is bad, this is bad. I have the fix that you can give me money and we'll come at that. And that's one thing. And part of the reason why the three of us have gotten together is not particularly because of that account, but because, like, and with the account that we're talking about, there is some information that's come out that person shares that early in my days when I was lifting, because that account's been around for a while, was I did find it quite helpful, and there was some informative information that came out of that. But then over time, just the narrative and probably the financial interests that have kind of come about with the development and of evolution of that platform, it's become a little bit skewed. But again, part of the reason why we're here having these discussions is to try and educate people with where the evidence actually lies. And none of us have a financial interest in what we're doing and what we're sharing here. It's just trying to save people from being bought into bullshit, essentially, for the greater good. So we're martyrs. There's low. So basically, if we could, I'm going to throw it to Aaron for the topics that we've discussed today. So first up, the pronation being an evil word, the bunions, and what we were just talking about as far as shoe width, everything like that. Do you have any sort of final thoughts as far as any of the topics that we've discussed, or take-home messages that you want to rattle off before we jump off?
Yeah, so like the way I'll give it like just some quick take-homes, like the pronation front, is it too much? Is it not enough? You'll never be able to know. There's no set limit. This is good, this is bad. And when you understand that, you realize, okay, it's movement. Then on top of that, you can't go without it. So as much as you want to say, or health professionals will tell you, oh, that's bad. Well, you can't walk without it. It happens. And on the bunion front, you know, if you thought the shoes are the only thing causing you this bunion, walk around your house barefoot for the day. And if you notice no improvement, is it? Now I know these things take a lot more time, but by the time most people do get bunions, they're in their 30s or 40s. Why did it take so long if the shoes continually stayed the same and just got newer? And if it takes 40 years to get that point, is it such a big thing that you got to worry about? Like you touched on, you know, can you move? Does it hurt? Things like that. A bit more important and relevant. And yeah, as for your final bits, Alicia, I think I have some plans in later posts on my own Instagram about lifting and the need for wide toe box shoes. In my opinion, don't. If your footwear is a problem and you don't like it, just get new footwear. There's no easier answer than that.
I like that. Kirsty, do you have any final bits to throw at us in relation to everything we've spoken about today?
I think at the end of the day, probably the main take home would be that everything is multifactorial. Like there's no one fix, and it's not like a one-stop shop that you can, figure everything out in one go. I don't know, human beings are so complex that I feel like we have all this evidence here to help us, and to obviously go off. But at the end of the day, figuring out what the client actually wants, what their goals are, and if they are just browsing on Instagram wanting to be informed, then for them to actually go, oh, would you take advice from someone that you didn't respect, or doesn't have that reputation behind them? If someone came to me that was a skier, and they were trying to tell me how to ride my bike, I'd be like, well, that's completely different. Like there's no correlation there. So just being mindful of where you get your information from, and if you trust the source, then obviously that's the best place to start. And then, question yourself, like with anything, if you want to improve in something, you're not just going to stay in this one area. You want to get better. So if you think that your shoes, as Aaron said, if you think your shoes are the cause, then go research a crap ton about some shoes and figure out what ones are best for you if you're just browsing on the internet. But if you really want to know, then go source someone who has the profession, or, maybe the experience, someone who's actually lived it personally. Then they can give you some guidance in regards to footwear. Pronation wise, it's a bit tricky. It's one of those things that's once again, it's just a factor. It's not, as we said before, it's not a diagnosis. It's just a simple observation. And I suppose last but not least, the plantar fasciitis. Just, I don't know, there's a lot out there about plantar fasciitis, and I don't know about you guys, but when someone comes in and they try to pronounce it, you already know that you're in for a good consult. So it's just kind of educating and, honing in on what actually matters. And what matters is getting that patient back to a great quality of life. And if you're going from a cost perspective attitude, then you're already in the wrong room. So, I always say, patient first or health first, money second. So if that's not your perspective, then you can't really go too far because money can't buy everything. So yeah, I suppose that's my view.
No, I like that, and that's something I'm very passionate about. And like as health practitioners, it's our vocation. It's how we generate our income. It's our livelihood. But I do feel that as health practitioners, we need to be very mindful of not putting profits before patients. And I think that's where a lot of people fail in their patient care, because at the end of the day, they see the patient as a dollar sign, not what can I do to help the person. So I'd probably say my take homes, and I'll bracket it out into the take homes for, say, the general public, but then the take homes for a health practitioner. So the take homes for the general public is more of like whenever you're going to see a health practitioner, you have the right to ask questions. And if you go and see someone and you have this problem that's developed, whatever it is, you've got pain somewhere, it's affecting the activities that you want to do, whatever's happening. When you go there, if the practitioner asks minimal information or tries to elicit minimal information from you regarding what activities that you get up to, what your occupation is, like, so the physical activities that are related to your occupation. So all of these other factors, your injury history, so all these other factors that for most of the things that we've discussed, if you're not being asked about that and it's very quickly scooting into pronation is your problem or footwear is your problem, if other things aren't being explored and that's where it's jumping into, that's actually a little bit of a red flag, and you have every right to question why is it definitely pronation. So I think just as from a consumer and a patient perspective, like I said, if you're seeing someone and they're jumping down it's your pronation that's the problem pathway straight away without asking further information about all of these other factors, that there is more evidence for majority of injuries that develop are probably more of a causative or contributing factor, then ask questions. You can push back, you can get a second opinion. There's so much you can do. You don't have to take it at their face value. In saying that, not all health practitioners are out to get you or rip you off or anything like that. It's just, we're trying to give you some information so you can ask questions to have more informed decision, or more of an informed place in your healthcare. And then my practitioner points is it's more so raising a little bit of a sort of self-reflection and self-reflection question, I would say. So are you very quick to jump on the biomechanics bandwagon when you've got someone coming in with a musculoskeletal pathology? Is it, okay, because I'm trained in biomechanical assessments, am I looking for some confirmation bias as why the biomechanics are causing the problem? I think it's more important, and evidence supports this, to ask about all of the other factors. So the intrinsic and extrinsic factors will be contributing to it. So if you haven't asked about someone's clinical history, so their injury history, their activity history, their metabolic status, depending on the pathology, sometimes it's not relevant. All of these other factors, if you're not asking questions about that before you jump down the biomechanics and possibly orthoses bandwagon, I would take stock, because if that's the practice that you're employing at this point in time, it is actually quite far removed in a number of cases from best practice and where the evidence sits. And not going to go into all of the specific pathologies because we'll do that another day. Then, look, I don't really need to go too much into that footwear dumpster fire. It's just, a narrow toe box isn't going to cause plantar fasciitis. It just, no. So many other factors that will contribute to that. So they're my take-home messages. I am so glad that you guys have joined me today. I can't wait for the next couple of episodes. And for anyone listening or watching, because this is going to shoot out on a number of platforms, if you want to follow me, I'm at P3 Podiatry. This is on the Instagram we're talking about. Aaron Wilson Rehab on Instagram, and then Kirsty at The Lifting Pod. But again, thank you everyone for joining us. Thank you too for joining me. I've really enjoyed the chat and can't wait for the next one.
Thank you.
Cool. Thanks, guys.